As promised, part two. Okay, Horner's syndrome. Um, so this is a sympathetic paralysis, basically. It can certainly be congenital. Often these are idiopathic. Nobody really knows where they come from, but they are evidence of intracranial tumours, trauma to the carotid artery or the sympathetic chain, or to the ganglions, the cervical ganglion. Um, So there are a lot of causes for this, not all of them are benign. One of the things that is done with this is to check on whether this is pre or post ganglionic. The preganglionics tend to be central problems, while the postganglionic tend to be peripheral. And what they do is they'll put a cocaine solution or something similar into the affected eye and watch for it to dilate. Now, if I remember this rightly, and I may have got this wrong, if it's postganglionic, the eye will dilate. If it's preganglionic, it won't. Or the other way around. Be honest with you, I can't remember. But this is differentiation at a different level to we're looking at. What you have to do is recognize Horner's when it's present, which isn't always easy. The signs of this can be extremely subtle and a little variable. Anyway, the distribution is in the face. There is a small meiosis, so there is some constriction of the pupil, but it can be very small, not noticeable in ordinary light. So often you have to look at these in dark light to see the contrast. The other eye will dilate and the affected eye won't, and you'll see the contrast between the two then. There's also a delay in its constriction from a dilated position or into dilation. So this should show up also with the confrontation test in the cranial nerves. So you have a small meiosis, there's a small ptosis. Now ptosis is defined as the eyelid covering the pupil or part of the pupil in the primary gaze positions. When you're looking straight ahead, you're getting some covering on that. That isn't always present spontaneously. This will sometimes only show up when the patient's tired. The other thing that happens is not just a meiosis, but the upper eyelid actually comes up. So the gap between the eyelids, a palpable fissure, is smaller than on the other side. That may be the easiest way of seeing the ptosis, that there is a smallness there. This isn't a levator palpebrae problem because you've obviously got the second one below it, the lower eyelid involved as well. This is a Muller's muscle paresis or paralysis, and this muscle is innervated from the sympathetic supply. So the levator palpebrae can fully open the eye. So if you ask them to correct the ptosis, they can. These two things, the small, the meiosis and the narrowed palpebral fissure, give the impression that the eye is actually retracted, so it looks further away. It's actually, though, an optical illusion rather than a pathological process, but it does look further away. There is also anhidrosis, and sometimes you have to know that this is happening by running your fingers down the face, because it isn't always easily visible, and the side you slide on easier is the drier side. This is particularly true in dry climates where the sweat evaporates rapidly. The other one is facial reddening, and this can be the minor or it can be quite startling, and it often only comes on with children. Tend to get this more than adults do, but with adults it's often related to exercise. So the patient may well see it, but you may not be able to. It can be difficult to see. As I say, this can be caused by intracranial tumours, damage to the carotid artery with the sheath, the vertebral, the nerve sheath running with it. Pancoast tumor is another one, and we'll talk about that next, I believe. Yes, Pancoast tumor. This is caused by an apical lung tumor, either directly pressing up on the lower brachial plexus and the stellate ganglion, or it can be via increasing the size of the lymphatic system. But basically, the distribution is face and arm. So you'll see a Horner's syndrome in the face and a lower brachioplexopathy in the arm. Those two together really do define the syndrome. However, it's possible to get lower brachial plexopathy without the Horner's component to it, and that's a bit more difficult. So you're looking for signs of a brachial plexopathy, but without the trauma that may suggest fracture or an avulsion problem. So now, lesser fractures, pedicle, laminar, transverse process, or subchondral fractures, but these are not the really dangerous fractures that we were talking about earlier. This can be non-central ligament tears or muscle tears. So these pains tend to be unilateral in distribution. But you still see the same thing. If this is a healthy bone fracture, you'll see the severest pain within the short time of the trauma. So what you see is an immediate onset of severest pain, pain on neck movements, muscle is tender if torn, deep palpation of the articular process if there is a joint fracture, or palpation of the neural arch or transverse process tips. Any and all of these things could be disruption of healthy tissue, and often this is a matter of exclusion diagnosis. So if you think they've got an anterolateral tear, it could be sternomastoid, for example. So you can palpate that by pinching it, not by pressing on it, because this may also be an injury to the carotid artery. You don't want to be pressing on that. So you would diagnose it as a carotid artery problem when the muscle tenderness is negative, but you've got to be careful how you do it. So a lot of this is the exclusion diagnosis. Okay, lateral stenosis, they're generally over 50, a bit younger for lateral stenosis than they are for central stenosis, but certainly over 50. It'd be unusual to find somebody who's not. But something to be said about these ages. It's worth remembering that not everybody with stenosis is older. This could have been trauma in the past, and it's just not been mentioned to you. Could be a congenital defect that's narrowed the canal already. And so a little bit more narrowing just adds to it. And there's also the possibility this could be episodic, although I've got non-episodic up there, but there's a chance that it could be episodic if we have a pre-stenotic canal that you're subluxing into extension at, in which case it may well show signs of lateral stenosis for as long as the subluxation is present. The distribution, there's aching in the neck, upper trapezius, upper arm, to different degrees, paresthesia in the affected dermatome, which is probably the most notable symptom. It's the one that usually brings a patient in. And there may be other signs of radiculopathy in the dermatome if it's bad enough. So you want to look for weakness and so on. Pain, they can get acute pain in the neck, but usually it's an ache. Rarely will there be neuropathic pain, but it's a possibility, and then of course paresthesia. So they get local pain on extension movements, particularly into the quadrants, the extension quadrants. There may be other signs of a radiculopathy, and PAs are generally stiff for the entire neck, but certainly on that segment it will feel stiff. Disc herniations. These are not true herniations because a herniation is one material moving abnormally through another material. In this case, it's an externalization of the homogeneous discal material. Because of the unstenotic processes, you rarely see this in the upper levels of the neck. They tend to protect that posterolateral corner, but with trauma they can direct it straight back into the spinal cord, which will narrow the canal, and if it's bad enough, obviously cause spinal cord compression. Anyway, the distribution, severe neck pain, severe arm pain, paresthesia in the dermatome if a radiculopathy is present. The pain is severe somatic, maybe neuropathic, depending on how much damage is actually done to the root and nerve. There may well be an antalgic, mild or moderate torticollis, and the levels affected are lower in the neck. C5, 6, 6, 7 are the most common segments. You just may have seen about half a dozen of them see stuff at C3, 4 and C2, 3, but it's unusual. Behavior, severe multidirectional range of motion loss with pain, severe signs and symptoms of radiculopathy if it's present, and an obligate functional loss. So it's not terribly common, but they do occur, and the biggest differential diagnostic problem here is between disc herniation and segmental dysfunction, and between lateral stenosis. Now, an atypical segmental dysfunction can look something like this as well if it's particularly painful. But generally speaking, it's disc herniation and lateral stenosis, particularly when both of them have a radiculopathy present, or either of them have a radiculopathy present, then it's easy to mistake the two if you're not thinking about it. But you're looking for the severity of the pains, the somatic pains, and not just the radiculopathy. Central stenosis, these tend to be older than the lateral stenosis, but again, a congenitally small canal may bring this age down quite a bit. The onset is gradual, it's non-episodic, and it is chronic. So the distribution is aching across the neck into the upper trapezius, upper arm, again, depending on how bad this is, and it obviously is likely to be bilateral pain. There's non-segmental paresthesia in the arms, and no other signs of a myelopathy. So if you haven't got the paresthesia, then it's easy to start thinking about this as degenerative arthrosis. But then you think about it in degenerative arthrosis, there's no indication that should give you pain anyway. So pain is aching mostly, rarely high levels of pain, and maybe paresthesia with this. So you'll see local pain on extension movements again. There may be other signs of myelopathy, such as reflex changes and so on. Hoffman's is your best bet for testing compression of the cervical cord. The only symptom that they may have, which may indicate neurological problems, is tripping. And it's usually when they've walked a little way and now the muscles are starting to get weaker, and so they lose dorsiflexion and they trip over their own feet. You can test this, just make sure it's not balanced, so test them in balance, and then you can do resisted isometric work or just have them pump their feet to see if it does get fatigued easily. Segmental dysfunction, the one that you should be seeing most of. Now, this is no different than segmental dysfunction anywhere else in the spine, except in detail. And in fact, it's not very different from peripheral segmental biomechanical dysfunctions. So they all have the same sort of presentation. That is, they are short-term episodic, moderate pain, moderate referral, non-obligate impairment, dominated by flexion or extension loss, moderate range of motion loss in flexion or extension, and PAs are appropriately positive. Now, in detail, what you'll see them have often is a headache, and the typical spondylogenic headache is suboccipital or occipital, and then it can spread over the top of the head and then retroorbitally, but that's when it's really severe. The most common variation on that is to come around the occipital, come around the side, forehead, and then into the eye. But those spreads are the most extreme of these referred pains. It's somatic pain, and there may or may not be referral to the upper trapezius, and not the upper trapezius and the upper arm. Rarely does it go below the upper arm. The pain is somatic in nature, headaches are spondylogenic in nature, and so is the upper arm somatic pain. Behavior short-term episodes, I've told you this, so it's exactly the same as other segmental dysfunctions elsewhere. Okay, so these are either the most dangerous things you're going to come across or some of the more common things. So I hope I've covered most things. If there's any particular condition you want to talk to me about, then bring it up, okay? And we'll see about designing a EIS for that. Anyway, I hope it helps, and I'll talk to you in a while. Bye-bye.